Chapter 41, Nursing Care of the Child with an Alteration in Perfusion Cardiovascular Disorders. Your learning objectives today, we're going to talk a little bit about the differences between adult and infants and children. We're going to talk about a few of the tests, but not too many we're going to go into. We're going to talk about some of those cardiovascular disorders. We're going to talk a little bit about assessments. We're going to discuss the psychological impact of those disorders of children. Talk a little bit about nutrition, and then talk about some teaching. So cardiovascular disease is a significant cause of chronic illness and death in children. And it's divided into two areas: congenital heart disease, obviously you're born with, and then acquired heart disease. Congenital heart disease is some kind of a structural problem, and acquired is something that they will get after birth. Many of those congenital heart defects can result in heart failure and failure to thrive in kids. Talk a little bit about the differences, what happens at birth. That circulation that the child is getting in utero via the umbilical arteries is going to be replaced with the child's own independent circulation. So about day 17 of conception, the fetal heart rate is present. So that's one of the first things they can see on an ultrasound is the heart beating. When that baby comes out, takes its first breaths, there's a lot of changes that happen. Dorsal go into those more in detail in OB. Some of the differences is, and the way they differ from adults is that infants younger than 7 years, their heart is more horizontal, and then as their lungs start to grow, their heart's displaced downward. When we think about infants, we talk a little bit about vital signs. We talked about how their heart rate's very high, and they can't really increase their cardiac output. So they do have a high heart rate. So increasing cardiac output would require them to be more tachycardic. Again, everywhere you read, the ranges of vitals are the same, but an infant's normal heart rate can go up to 160, and that can be normal for them. So as we noted before, heart rate's high, blood pressure is low. Talked a little bit about this. So congenital heart disease accounts for a large percentage of birth defects, and then acquired heart disease can come from complications of illness, things like that. We'll talk more about that in other slides. Some of the disorders that we see, one of the biggest ones is tetralogy of flow. So those have decreased pulmonary blood flow. When you're not going to have to remember any of the medications for heart disease, because it's typically the same as it is for kids. So we really don't have many differences there. You sometimes will see with congenital heart disease, we'll see some of the defects associated with certain syndromes, especially Down syndrome. And then about a third of the infants with congenital heart disease will have serious enough diseases to cause death. But lots of advances. They're noting cardiac defects in utero now, and so being prepared for them at birth. They don't really know exactly why congenital heart disease happens. So it could be genetics, and that happens sometimes with the kids who have chromosomal alterations, maternal exposure to factors like infections, illness, alcohol. There's a syndrome called fetal alcohol syndrome, and they often have some heart defects. We talk a little bit about categorizing them. I don't expect you to remember all these different heart defects, but decreased pulmonary flow, that's when we see the tetralogy flow, and that is the combination of 4 different heart defects. Those children usually have a lower oxygen saturation. Disorders with the increased pulmonary flow, you can have a patent ductus arteriosus, so that duct should close, but it's still open, and then your atrial septal defect and ventral septal defect. We kind of see those with the adult world too. Obstructive disorders, so something is causing an issue. Coarctation of the aorta, so that's a very narrowing of the aorta, which will cause decreased blood flow. And then you have aortic stenosis, pulmonary stenosis. You have some mixed disorders. So when you have mixed disorders, often those kids are mixing their arterial and venous blood, so they'll have a lower O2 sat. So transposition of the great vessels, they're just flipped over. The other mixed disorders we don't really ever see too often, so I'm not going to go into those. So kind of just hearing about this, thinking about when a child has a congenital heart problem from a defect, we might be aware of where they occur in the body, in the heart. We're going to talk a little bit about infective endocarditis. So that is an acquired heart disease because they, after birth, they had obtained this from something. Obviously, it's an infection. It can affect the heart chambers, the septum, the valves. Children who have congenital heart problem or those that have a prosthetic valve in place can have increased risk. Infections from central lines can cause it. IV drug use, obviously we don't see that in infants. Bacteria, sometimes we see it with bacteria of the mouth, so decaying teeth. And then sometimes what we would do is antibiotic therapy for about 4 to 6 weeks. Rheumatic heart disease is usually from strep A, so maybe an untreated strep infection, most common in school-age kids. And then usually it's about 2 to 4 weeks after the initial strep infection. Sometimes it's because it's untreated or not treated properly, and it could be prevented. So usually they will go ahead and give a 10-day course of penicillin and some steroids, anti-inflammatories for rheumatic heart disease. Fever. They have rashes, sometimes like a lacy rash, pain, swollen joints. Kids that are at risk for cardiomyopathy, so that's where the myocardium can't contract, so the heart loses its pumping full mechanism. And this happens with kids with some genetic disorders, with congenital heart defects, or if they have some type of infection. So their heart just doesn't fully function. And sometimes we see kids who have muscular dystrophy, especially Duchenne's, if they've had any type of surgery, high blood pressure, drugs, alcohol, maternal diabetes, lots of risk factors for cardiomyopathy. And then when they, progress to cardiomyopathy, then they're going to have to be on more medications, and they're going to have a harder time with maintaining their cardiac output. Kawasaki disease is another one that we see. It's a vascular heart disease, usually high fever, chills, irritability, inconsolability, vomiting, diarrhea, abdominal pain. Usually affects about kids 6 months to 5 years old, leading cause of acquired heart disease. And we see it more frequently in Asian and Pacific descent. It could be self-limiting, but it also can cause things like an aneurysm. So treatment really focuses on that inflammation, reducing that inflammation, and then aspirin, and then sometimes they'll give IVIG. Kawasaki disease is on the rarer side, but we have been seeing it lately. And then your chapter goes into high levels of lipids. So hyperlipidemia. So we see this. We're seeing kids with more younger kids with hyperlipidemia. So again, early screening, management of diet. So cholesterol, and then there's some guidelines by the Bright Futures guidelines to recommend screening between 9 and 11, and again 18 to 21. I'm sure in the meantime, in the middle, we screen also, but these kids are more at risk for problems later in life, so MIs, any type of peripheral vascular disease, cardiovascular disease, and stroke. And so really assessing kids, education on diet, exercise, things like that to reduce their cholesterol levels. Hypertension. So we see hypertension. I won't go a lot into that because you did learn about hypertension in med-surg, but we are seeing it in the younger kids. It's usually associated with increased body mass index and then that weight circumference. Kids who are hypertensive often have long-term health effects that follow them into adulthood. And making sure that we are, again, doing assessments, are doing education. Your book talks a little bit about primary and secondary hypertension. It doesn't really matter what type, we're still going to do the same type of education on this. So physical activity, diet, things like that are important. And this goes a little bit into primary and secondary hypertension. So additional factors of risk is if the family has any type of heart disease history. They need to make sure if it's a first-degree relative, they're more at risk. Again, hyperlipidemia, diabetes, obesity, inactivity, stress, and high cholesterol could all lead to cardiovascular disorders. Signs and symptoms would be cyanosis, edema, clubbing. So here's a picture of clubbing of the fingers from hypoxia. Retraction, so increased work of breathing. Seeing their pulse, so we talk about jugular vein distension and then abdominal distension. And so what is the goals is to improve the oxygenation. So if they have a defect that makes their oxygen level low, you want to improve that. Again, nutrition, diet, exercise, and then family coping. It's very hard with any congenital defect for parents to accept this. Post-op care if they have any surgeries, preventing infection, and then education. Psychosocial interventions, so really explaining what's going on. A lot of times parents, we may assume that they're going to Google symptoms and really look at that, and a lot of parents don't. Using the language that they can understand, listening to them, and then time to address the questions, and then participating in care. So we would do this with any chronic illness, disease. Nutrition, we talked a little bit about that. So not only proper nutrition, but also kids with congenital heart defects sometimes have an increase in their energy expenditure. So rest periods are important. Sometimes with infants with a cardiac disease, they will double concentrate the formula. So they have to eat, to get the calories, they would eat less volume because eating stresses your heart. So they want to, and increases your oxygen consumption. So decreasing that helps. And then we talked a little about in skills about G-tubes, Mickey buttons. So however we can increase their nutrition, we would work on that. Okay.